talking generally about shock and focus more on sepsis. So these are sort of the big take-home points from the first section here: thinking about oxygen delivery, assessment of shock, and then this here is just I've just written down numbers. Just this isn't a quiz. When I ask you questions, it's so that we can kind of talk about interesting questions. It's not trying to test you. So, and then this is I have this slide later on.
Now, pull the thing out.
Yeah, because it may think it's off when you have it in.
Oh, gotcha. Okay, great. Gotcha. So this is just, these are sort of, and then I'll come back, I'll show this slide again later on, but I decided to move it up to the beginning just to emphasize these points. So these are the things that I see residents across the board, sort of mistakes that are made. And I think that I just want to emphasize these as we go through, that when we talk about numbers, the numbers I think are important, but they're informative. They're part of your hypothesis testing, right? So all we're doing, especially in the ICU, we're taking care of patients, a big part of what you're doing is you're asking a hypothesis. I think this patient has X. I think they'll respond to Y. And so you have to sort of keep in mind what the whole clinical picture is. So the numbers are important, but someone who's not making urine and has a CVP of 10 and has a pressure requirement that's increasing, is you need to sort of think about, the answer is not necessarily, well, I'm going to stop getting fluids, right? You have to sort of think about who they are and what's going on, and not get beholden to just what is this number and follow a guideline kind of blindly. Okay, so I would just make that point that, and equally someone who has sort of sepsis but has a CVP of 6, who's 25 years old and they're off pressors and they're making urine, you don't need to give them another 4 liters of fluid to try to get their CVP to 8, right? So kind of use common sense. You guys know this, but it happens at 3 a.m. when you get called that that you're sometimes you forget these sorts of things. So look at the patient, use the numbers to test your hypothesis, to validate what you're thinking, but don't be so beholden to the numbers that you forget about what you're doing. Rapid cycle followed with your interventions, right? So if you're giving someone a fluid bolus, you need to know what actually happens with that. If you're starting someone on dobutamine, you need to reassess what their central venous status or their lactate is. So if in the era of reduced time in the hospital because of work hours, it gets harder and harder to know if you do an intervention of what actually happens. One of the reasons I love the ICU is that it allows you to do this in a very rapid way because you get so much information quickly. So follow up on what you do and see whether or not patients respond. You'll learn something, but equally or arguably more importantly, you'll know whether or not what you're doing is working and whether or not you need to reassess the hypothesis that you had to begin with, and whether or not you need to go back and say, well, is what I really think happening actually happening? Do they actually have septic shock, or is there another cause for their shock, or for something else going on? And then the other is that if the patient's not doing what they're supposed to be doing, if they're not responding as you would expect them to respond, then don't be a hero. Ask for help and get other more experienced people to think about the patient with you to make sure you're not missing something. So we'll come back to those and hit on those, but just so this sort of section of the talk, we'll kind of cover some definitions of pathophysiology. One of the focuses will be early management in this. And then I'm going to talk briefly about post-resuscitation management, and mainly sort of outside of that first 6 hours, how we handle fluids and things like that. How do you approach fluids in a patient who's still on pressors at hour 24? Do you give them fluids or do you not? Those sorts of questions that I think come up frequently. And then then this I also kind of think throw in, what do we do with insulin? What do we do with steroids? All those sorts of things. All right, so I would, as a reference, this is a very good overview. Now again, the surviving, you should probably all read this at some point. The most recent surviving sepsis guidelines published in 2013, or just earlier this year. They are very comprehensive, very much evidence-based and in line, I think, certainly in line with expert opinion as well as what the evidence, the state of the evidence is. and I think is a generally good reference for you guys to go to and sort of think about, especially when you're sort of asking yourself, what pressure should I use and what fluids should I use and those sorts of things. So it's a good reference. I'd encourage you to take a look at it. There we go. All right. So one of my interests when I was an intern, my second rotation was in the ICU, and I remember admitting 2 patients on the same night. One of both, 55-year-old men with kind of typical comorbidities, a little bit obese, diabetes, maybe a history of heart disease, and one of them had come in, febrile, hypotensive, MRSA bacteremia. The other had come in actually to our step-down unit for sort of a post-MI kind of. Our step-down unit was an arrhythmia unit concerned to get positive cardiac biomarkers, and then ended up actually having MRSA bacteremia for unclear reasons. One of them we fluid resuscitated, did fine, went home a few weeks later. The second guy, the guy who went to another unit first, and then ended up coming to us sort of for missed sepsis, so a little bit of a later presentation. Died within about 12 hours. And so one of the reasons that I was drawn to critical care is that you have sort of relatively common patients and obviously different courses of illness and time courses, but you can have the very same insult that affects patients differently for reasons that we don't fully understand. And certainly a lot of interest with genetic, with GWAS studies and trying to tease apart what are the sort of innate risk factors for developing sepsis, and for developing and recovering from various critical care syndromes, but largely what we deal with in the ICU are these syndromes. We deal with ARDS, which is a syndrome. We deal with sepsis, which is a syndrome. And so the power of syndromes is that it really allows for grouping, clinically it allows grouping of patients and allows sort of big picture protocols like this to be sort of bundled type care for patients who act similarly and can show benefit. What it is less helpful for, and certainly this is more proven true in ARDS than it is in sepsis, is that it's not nearly as powerful in looking at specific interventions because you have a lot of different patient phenotypes that are feeding into that syndrome and a lot of different etiologies that are feeding into those syndromes. So very good, I think, for non-specific type interventions where it is not as helpful as for pharmacotherapy. So we'll see that later on in the discussion when we talk a little bit about specific pharmacotherapy that's been investigated for sepsis, for which there is none except for treatment of the underlying infectious etiology. And this is just, again, this is about ARDS, but this was just what I would sort of characterize as the power of grouping patients into syndromic definitions in the ICU. That is less true in sepsis, but certainly true in the acute respiratory distress syndrome, which is that over time, this is not the mortality benefit from any of these studies. So if you recognize it, so these were the original low tidal volume ventilation study, PEEP, conservative versus liberal fluid management in ARDS. This is related to sort of fatty acids, and this was beta agonists, beta agonists in ARDS. So these are, but this is the control group mortality in these studies, published studies, that was decreasing over time, and that's probably largely due to a protocolized approach to the syndrome, in this case of ARDS. You can see something similar, but as I said, less impressive in sepsis, as well as overall improvement in taking care of critically ill patients, and in terms of things like preventing ventilator-associated pneumonia, preventing pressure ulcers, improved nutritional status, all those things that are incredibly important when you're taking care of critically ill patients. So,
sorry.
No, it's okay, it's all right. So definitions, so now we're thinking specifically about sepsis, SIRS, what is the systemic inflammatory response syndrome?
So like a heart rate greater, it's like they have to have 2 or more of.
What's the 4 criteria?
4 criteria.
Yeah, just throw out the variables. You don't have to use them.
Heart rate.
So white count of less than 4 or more than 12?
Yeah.
Yeah.
Heart rate greater than 90.
Systolic less than 90.
Yeah.
No,
No, actually,
not
so blood pressure is number one.
Respiratory rate greater than 20.
Temperature more than
Temperature.
38 degrees centigrade or less than 36 degrees centigrade.
Yeah. So, exactly. Okay. So, three of these are what you get before you get any labs. Right. These are just vitals. So, hyper or hypothermic, tachycardic, tachypnic, and then either leukopenic or having a leukocytosis or the bandemia clause. So that's SIRS. Sepsis equals SIRS plus you think they have an infection. And severe sepsis equals sepsis plus sepsis-induced tissue hyperperfusion or hypotension. All right, I've already shown you this slide.
Somebody just check all the connections, please, push them all in. I would know for sure now.
These are your markers of end organ hypoperfusion and end organ dysfunction, acute organ dysfunction. We've already talked about this in terms of thinking about pathophysiology, right? So early sepsis, third space loss, drop in CDP, dropping your wedge pressure, your pulmonary artery occlusion pressure, decrease in cardiac output initially if you're dropping your preload enough, and then after fluid resuscitation, you tend to increase your CDP, increase your cardiac output, and you'll often see the profound drop in SVR after fluid resuscitation. And then with sepsis and tissue hypoxia and lactic acidosis, you have a few different pathways here that are occurring: increased nitric oxide synthase, ultimately leading to vasodilation. You have lactate and vascular smooth muscle, right, also leading to vasodilation. And this arm here is actually why for a while the thought was that vasopressin as sort of a second-line agent or maybe even a first-line agent, would have been beneficial in sepsis, is that you get vasopressin depletion, you get loss of your vasopressin stores early on in sepsis, and reduction of your plasma vasopressin. That's maybe less true now, though I would argue that in patients with liver disease especially, this can be profound. But this kind of picture here, the sort of, as I said, sort of that macrovascular, right? The big picture hemodynamics aren't the whole story in shock, in septic shock at least. There's the role of the microcirculatory failure, and we have pathogen factors and host response. I think I took out some of these slides, but the role of microcirculatory failure. So there's been a lot of interest in this idea, especially this phenotype of patients who have a relatively preserved or even a high central venous sat. You may have seen them at some point in patients with really severe septic shock you're taking care of who central venous sat is 90% or 85%. And the sort of this idea of microcirculatory failure you could characterize as the patients who have a normal or high central venous sat, maybe with a lactic acid that's either persistent or increasing or failing to respond with resuscitation. So a healthy volunteer here, so this is microcirculatory blood, sublingual blood flow using a sort of microscopic type image. These are healthy volunteers here, and this is sort of a patient who meets that criteria for microcirculatory failure. So you can see here significant endothelial damage and dysfunction. And if you looked at their hemodynamics, right, it would sort of make sense. I actually did include it. So this is mostly just to kind of make you aware that this is less in kind of our lexicon right now when we're talking about sepsis. It's something that you, as you read evidence into the future, you'll probably hear more of this kind of general kind of gestalt approach to pathophysiology of sepsis. This idea of PAMPs, pathogen-associated molecular patterns, which are really associated with the specific infectious etiology. You have pattern recognition receptors, which would be on your sort of immunologically what these are acting upon and causing sort of a sepsis or SIRS type syndrome. And then danger-associated molecular patterns, which are actually within mitochondria. And so I included it. Yeah, this was just basically, so here, if you have basically cellular damage and mitochondrial damage, you have release of these, which can lead to SIRS type response, right? We've seen that in the sort of lung injury world. This helps explain why patients with, say, non-thoracic trauma may get ARDS or lung injury. And then you also have the pathogen-associated molecular patterns and bacteria, viral, fungi, and parasites, again, causing a triggering of the innate immune response. Evolutionarily, the reason this was published by Carolyn Calfee and Mike Mathey from UCSF in Nature is, bacteria evolved prehistorically into mitochondria. And so you had this homology between mitochondria and bacteria, so, and equally some homology between, say, mitochondrial DNA, the DAMPs, and the pathogen-associated molecular patterns that would, because of their homology, would cause similar type of activation in the innate immune system. So this is not, I mainly just put this there just for your kind of general benefit. This has no clinical application whatsoever at this point. Maybe someday, but.
Interesting.
And this was just, I think it's just kind of cool. So these were a group of researchers who looked at the release of mitochondrial DAMPs following trauma, and then I think actually gave those DAMPs to rats and saw increased lung injury. So kind of cool, something interesting. All right. So that was kind of based a little bit of basic pathophysiology in conjunction with what we talked about in shock. We're going to talk about early management now. We'll spend probably the bulk of the time here talking about early management. So resuscitation, we're going to focus on early goal-directed therapy. We'll talk about vasopressor selection, use of inotropes, treatment of underlying infectious etiology, and then we'll also touch on a couple of other issues that I mentioned, steroids, glucose, this sort of thing. All right, so our second case, 55-year-old man, history of coronary disease, had a PCI with multifocal infiltrates, mild hypoxemia, fevers following up a flu-like illness a couple weeks afterwards. He's febrile, he's tachycardic, blood pressure 100 over 55, MAP of 65, a little tachypnic, a little hypoxemic, urine output. He's been in the ER for a couple of hours, and he's had 10 mLs over the past couple of hours. White count's 15%. I'll spot you and say he had a 12% angina. He appears to be in distress, has cold extremities, and he seems confused and anxious. What do you want to do? How do you get fluids? Just, here, have a cup of water, drink it.
Establish IV access.
No, first,
To
like,
find
see
the-
orthostatics and all that to see if he's actually volume depleted or not before starting fluid.
Yeah, he's confused, he can't stand up.
Yeah.
We'll check CBC, PMP, ABG, give oxygen, IV fluid bolus,
Oxygen, sir.
and again examine the patient.
And how do you want to give the fluids?
So you
Go ahead.
so you have to have like two wide gauge peripheral access, but if you are not able to administer fluids, then it's best to have like CVP, central line in these patients. So first you need to give a bolus of like 1 to 2 liters of fluid over 30 minutes, and then most of the times you have to give like 1 to 2 liters like over 30 minutes, but the requirements can be as high like as 4 to 6 to attain like a CVP of 8 to 12.
Yeah, so and we'll get to sort of the hemodynamic measurement in a minute. Exactly. So I think often the rush is we got to put a central line on. Do you need a central line? What's the fastest way to get fluid?